Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Many of the people who take psychiatric medications may want to stop taking them at some point, but that's something they're advised not to do suddenly. For help understanding why, I'm talking with Dr. Thomas Schwartz, the chair of Upstate's Department of Psychiatry and Behavioral Sciences. Welcome back to The Informed Patient, Dr. Schwartz.
Thanks a lot for having me. Great to be here.
Why is it that we aren't supposed to stop taking some psychiatric medications cold turkey?
I think there's a couple of ways to answer that. And one of the scariest answers is because people get hurt. So there are some medications that have withdrawal syndromes or discontinuation syndromes, and people can die. It's scary, right? The benzodiazepines, the sedatives in particular, people can have seizures, repetitive seizures, and that gets really scary. So on one level, people can really get hurt. Maybe the middle level is more of what we call discontinuation syndromes, where people do not die from stopping a medicine, but they feel awful. So some of our antidepressants that are shorter acting that elevate serotonin, there's something called serotonin discontinuation. So imagine feeling like you have the flu or COVID, achy, malaise, but you don't really have a virus. The withdrawal can do that to you. Headaches, stomach aches. Sometimes all your emotions come back, all that sadness had disappeared, and you get side effects, sadness, weepiness. And nobody wants to go through that. That won't create seizures or kill you, but it's awful to go through. And then maybe on a more mild level, we can get headaches, stomach aches, and it's something you can put up with for a couple hours a day or two. So I think depending on the medication, your risks could be really high versus minimal. And then yes, there are just some medicines we can stop without a problem.
So would some of those things happen just if someone forgets to take their medicine one day? They might get some of those symptoms?
That is correct. Yeah. So every now and then there's medications that can do that to you. And certainly some patients are more sensitive to others to these kind of side effects. But some of the what we call short acting, some of those short half-life, how fast do these drugs leave your system? So some of the sedatives like Xanax, alprazolam, all the sedatives, the benzodiazepines, some people, if they miss a dose for a day, will start getting what we call rebound anxiety. They feel twice as anxious as what we were treating them for. And some people, we call it micro withdrawal, rebounding. We have all these fancy terms, but some people can feel that. The shorter acting, short half-life, some of the antidepressants, venlafaxine, which is Effexor, desvenlafaxine is Pristiq, paroxetine, Paxil. These three drugs are known to be shorter acting, and some people will go through that serotonin discontinuation feeling if they miss a day. But other drugs that are longer lasting are more forgivable. So if you're on a longer acting sedative, anxiety medicine, you're on a longer acting antidepressant, you won't have any of that at all.
So the longer you've been taking a medicine, does that predict how rough of a time you might have stopping it?
More often than not, I think that's correct. So the higher you've been dosed on a medication and the number of weeks, months, or years. So think of it, the more ingrained it is, the more your brain is used to seeing it, the more shocked your brain's going to be if it goes away quickly. So that's probably true.
Now, do some of these drugs, the psychiatric medications, do they help people become more forgetful? Like, do they struggle to remember to take their medications?
So that's an interesting question. Maybe, like everything else, maybe. So we do have medicines that can hurt attention, concentration, and memory. So those sedatives, the anxiety medicines, Valium, Xanax, Klonopin, particularly at bigger doses, or as people get more elderly. I'm getting older myself. I'm a bit more forgetful. I can't do the things I used to do when I was 30 or 40 even. So as your brain ages, it doesn't store memory as well, right? And we don't focus as well. And so when you're on a medicine that hurts those operations, right, the sedative, anxiety, maybe, yeah, that can get worse. I don't know if it gets worse to where you forget your medicines, but maybe. The epilepsy medicines, we use those to treat bipolar disorder. Sometimes we use them to treat anxiety disorder. Those medicines slow down how fast your neurons fire in your brain, the nerves in your brain fire. And so sometimes that can hurt memory at bigger doses as we get older. So, yeah, I think there are certain medicines that do have memory side effects. I hope it wouldn't get as bad as to where you would forget your medicines, but anything's possible, yeah.
Are any of these medications intended to be for life, that people are supposed to keep taking them forever?
Well, that's the question of the day. And even though I went to psychiatry school, I do not have a crystal ball. And I guess I'll give you some rough guidelines, but remember, every patient's different. Every patient is unique. One maybe legal answer is when the FDA studies medicine, sometimes they're only studied for 8 weeks, and then we use them for 8 years. Maybe at the most, some of the antidepressants are studied for a year, 2 years, but we use them for 20 in some people. So, I have to use some caution. Or patients, when they read stuff, this was only approved for 8 weeks of work, and then people may want to stop. And that's why you need to talk to your provider, right? Your doctor, your nurse practitioner, and whatnot. Every disease, every disorder has different rules. So I work mostly in depression, people that suffer from major depression. If you had a relatively simple depression, you were depressed for 8, 9 months and we got you better, I probably only need to treat you for a year. So even though the study showed 6 to 8 weeks, we use it for a year. We need to convince your brain not to go back into depression. If you have been depressed 2 times in your life, been depressed for several years, I might need to use that antidepressant for 5 years. Think about it, 8, 9, 10 years depressed, 2 depressions in your lifetime. We may need to treat your brain longer. 3 episodes of depression, decade to lifetime. What if in your depression you tried, sadly, to kill yourself 3 times and almost succeeded? We're going to treat longer. We need to convince the brain not to go backwards, right? Back into the depression. So almost every disorder, schizophrenia is different from bipolar disorder, is different from panic disorder, from depression. But the more severe your illness has been, the longer it has lasted, the greater we need to treat it. And the quick parallel I would share with you, I know we're talking about mental illness, psychiatric disorders. We think these are all parts of the mind, let's say, but these are medical conditions. And there's a difference whether you have a sore strep throat, where you get 7 days of an antibiotic, and what if you have a massive sinus infection, 2 weeks. So even in medical condition, we have time frames, because if you don't get all the bacteria away, the sinus infection comes back, right? That's why we need 2 weeks. We might need stronger antibiotics. We might need 2 antibiotics. And in the world of psychiatry, it's somewhat similar. You kind of have these time frames, and you need 1 medicine for how long, 2 or 3 medicines for how long. And that gets very individualized. So I want to be careful here saying it's 6 weeks, 8 weeks, 1 year. The patient is more important than any statistic, right? So we got to be careful, but some people need a lifetime of treatment.
Well, it sounds like it's very patient specific. What are the reasons that patients give for wanting to stop a medication?
Well, they often give me good reasons, right? And one of the big ones is this thing isn't working. So why would we stay on a medicine that's not working? So with a lot of our medicines, there's these delayed effects. They don't work on day number 1, and we start the medicine low, and over several weeks, we increase it to a good dose. Well, let's say after 2 to 3 months, it's not working. We absolutely should safely remove it. Now, again, some medicines you can quit cold turkey. Most of them we should gradually come off. I think theoretically with my patients, I like to do everything gradually anyhow. So we prevent withdrawal, we prevent rebound, and the brain doesn't like surprises. So again, if we raise your medicine very slowly to try to not hurt your brain or you with side effects, why don't we do it slowly going backwards? So I always ask my patients, especially if the drug isn't working, I know you want to get off of it. It failed you. It's a bummer of a medicine, but let's just make sure we take it off slowly so you don't get hurt in the meantime. So one, to answer your question, one is the medicine just didn't work. The next one is side effects. Nobody wants to stay on a medicine with major side effects. And again, I would want to remove that medicine as fast as we can because I want your side effects to go away. But I also don't want to give you withdrawal, rebound, or discontinuation side effects. So sometimes we have to navigate that. Sometimes we need to use other medicines like as the antidote, like Let's say if you have an upset stomach, you have headaches, right? Your blood pressure goes up. We have other medicines that we will do to safely get you off medicine, treat your side effects. So two of the biggest reasons are it's not working and I have side effects I don't like. My advice to the audience is if you have side effects and the medicine is working, your immediate reflex should not be to stop your psychiatric medicine. We don't always find medicines that work, right? So if the medicine's working great, but giving you stomach problems, please talk to your doctor, your nurse practitioner, somebody. Maybe we treat the stomach problems, right? So the goal is it's easier to fix a stomach problem than to fix a depression sometimes. I always warn people, sometimes there's side effects you probably should put up with and get treated for. The other, I know it's a long answer, but it's important. The other way to think of this, when I talk to my patients who are getting some side effects that want to stop the medicine, but this medicine seems to be working and curing them. I use the cancer treatment analogy. I don't think any of us would want to have chemotherapy and throw up, have nausea, lose our hair, lose weight. It's terrible, but we do it because we want to live, we want to survive. And I'm not comparing, let's say, depression to cancer, but depression does kill people. Schizophrenia kills people. Suicide is a problem. So if the medicine is working and we can treat nausea and vomiting in cancer care, maybe we can do that for you in your depression because we finally got you doing better. So I think sometimes it's worth a discussion of how can I put up with these side effects and get them treated. I spend a lot of my time as a psychiatrist having these discussions. So side effects don't immediately mean you need to stop it. So one is the drug doesn't work. Two is there's side effects. And the third is, I think I'm better. I don't need this anymore. I'm better. I'm feeling great. So what do you do with that? I think sometimes the patient is right. If, let's say, you've had a year of doing great after 8 months of depression, I think the patient's right. Let's stop the medicine. What if you've only had 3 months of doing better? If we stop this medicine, you and I have to have a discussion. Your depression could come rip-roaring back. I don't have a crystal ball. You could be cured, but the data seems to show it's going to want to come back. We don't wait a little longer. So I try to work with patients to wait it out a little bit more, then discontinue. But a lot of people, that's the tricky part, is they feel good. I feel good. I'm the doctor. I got them better. But they want to stop it. They're not having side effects. They just don't like being on it. They feel great. I don't want to be taking pills. I don't want to pay for the copay, go to the pharmacy. I love you, Dr. Schwartz, but I don't want to keep coming to see you for visits. I feel great. My job is to try to not let people quit too early. So it's weird, but people feel good and they want to stop things. And our job is to educate patients. It might be a little bit too soon.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with psychiatrist Thomas Schwartz, who leads the Department of Psychiatry and Behavioral Sciences at Upstate. Now, it sounds like the safe way to come off medications once the provider agrees that it's time is gradual. So what should a person expect as they're gradually coming off a medication? How do they know it's working?
Again, I wish I had short answers for you sometimes. It's very specific to the type of medicine you're coming off, what psychiatric condition you're treating maybe. But if we do it right, and you gradually remove a medicine over several days or even several weeks, there are some medicines we take several months, you shouldn't notice a difference, right? So you and your brain are coming gradually off of medicine that was hopefully helpful to you. If we do it slowly enough, there's no side effects. We do it slowly enough, we don't convince your brain to create new problems, new anxiety, new sadness. We give your brain the chance to rebalance its chemicals and its activity. If we do it right, you don't have side effects, you don't feel worse. And that's what we, of course, like to see. If we do it wrong, I think wrong's a tough word, but we don't have crystal balls. We don't know how fast sometimes we can take people off. So if we move too fast and you start getting withdrawal headaches, we'll just push your medicine back up, fix your headaches, and we'll go twice as slow. And when you look at that model in the addiction world, we treat people, let's say, with heroin addiction, and we put them on medicines like methadone, and it's called a detox protocol. And you work the medicine down slowly till you kind of hit a wall where they do start having withdrawal symptoms. And same thing, you have to raise the dose up, wait a little longer, lower it, smaller increments over a longer time. Then you kind of slow it down. And so again, the medicines I'm talking about aren't the addictive ones necessarily. We're not treating addiction, but any medicine, if you run into side effects, we can just slow it down, right? And that should be able to fix any side effects you're going through. If we're lowering a medicine and you think, let's say your anxiety is coming back, we can raise the medicine back up and wait a little bit longer. It's okay. So there's no, you need to be off this in 6 weeks, right? Every patient we see is going to kind of be an individual protocol.
So what about the timing of tapering off? Does it matter? Like if you choose, okay, I'm going to be going on vacation next week, I'd like to start tapering then, or I'm going to be starting a new job next week, I want to start tapering then. Do you take that into consideration?
Yeah, I think you do. And I like to say life always happens, right? Sometimes it's my idea. I think you're doing great. Let's take you off this medicine. And they're like, but I'm going on vacation next week. I don't want to run into side effects withdrawal. I don't want to get sad again. Okay, we can wait till you come back. So I do think if you have a big life event, getting married next week and starting a job in 3 weeks, well, I think getting a job and getting married and vacation are great, but they're also stressful, right? So everything comes from 2 buckets. There's good things and bad things. Why don't we let you get settled? In 3 months from now, let's then meet and consider then doing your tapering. So I'm a big fan of certainly figuring out what the patient wants and being a partner in their care, but sometimes we're going to suggest waiting. And again, there are trickier medicines to get off of. Those wouldn't be ones I would start in 1 week or would stop in 1 week. And, I think I would wait till those big life events are over. And then you monkey around with titrating people off.
Now, what about any other strategies that you would recommend as someone is tapering off? Is there a diet they should follow or things they should avoid? Or do you want them focusing more on sleep? Are there things like that, lifestyle types of things that are important?
I'm always an advocate of exercise. Can I tell you exercise helps you avoid any kind of withdrawal? No, I can't look patients in the eye and say, run on the treadmill 30 minutes a day and you won't get headaches. But in general, for mental health, if you look at exercise, and I'm not talking about running marathons, but 20, 30 minutes a day of some exercise can be a good antidepressant right by itself. So if you haven't been doing those things and you want to increase your protective factors about, let's say, getting redepressed, maybe you could do some exercise, but I'm not sure that's going to prevent withdrawal type side effects. And diet, there may not be anything there either. I think when it comes down to it, there's the mathematical equation of what medicine you're on, how long is it in your system, how many milligrams can we lower every couple of days, every week. There's just, in my mind, a mathematical reality of this is how to get people off. And I'm not sure we've found other things that can help that. We do have detox protocols. So if we know you want to get off a narcotic pain pill like the methadone story, if you're on a sedative like Xanax, Klonopin, we detox people off of those with longer acting sedatives. The antidepressants that we talked about that create serotonin withdrawal, we put people on a medicine like Prozac, fluoxetine's the generic. That drug, every tablet lasts a week in your system so you don't run out of it. So we've gotten pretty good to avoid withdrawal outside of, we don't think diet works, we don't think exercise works, but we do have detox protocols. So if you're really having a hard time, again, go ask your doctor, every time I lower this, we run into headaches and stomach aches. Is there a detox protocol? Can I go on something else to make this easier? And the answer is usually yes. I don't think patients have to suffer.
You mentioned serotonin withdrawal. Can you explain what that is?
So serotonin withdrawal, in the technical jargon, we call it serotonin discontinuation syndrome. So if we got real picky, it's not a formal withdrawal like alcohol withdrawal, Xanax withdrawal. So it's a little less severe and it typically isn't life-threatening like some of those other things we mentioned. But what most of my patients will go through if they stop certain antidepressants too quickly, they'll get kind of a malaise, tiredness, maybe even muscle aches, joint aches. People say it feels like COVID or having the flu. And sometimes people come in thinking they have a virus, but it's really that their brain and their body are now too low on serotonin. Headaches and stomach aches can happen, nausea, vomiting, diarrhea. Serotonin receptors line your gut basically, so they get upset. So it's no fun. It's like having the flu or the stomach flu. And one thing that we see often, and it's the only time this happens in medicine, patients will say they have brain zaps. And they feel like there's a zippiness. It's not a shock. It doesn't hurt, but it's like there's these zips, and they call them brain zaps out of nowhere. So if you ever have that experience, that's probably withdrawal from serotonin and an antidepressant. But most patients, it's malaise. They feel like they have a virus. They're under the weather. And then maybe another complication is all their sadness comes back, all the anxiety comes back. And it's that kind of rebound phenomenon. It feels different than the sadness they came in with. So maybe they were depressed and felt blah, but now they're depressed and can't stop crying. It's different. And that sounds like the kind of chemical withdrawal, right? So sometimes we have rebound sadness, rebound anxiety, but it can take any one of those shapes. And every patient's different, every medicine's a little different, but that's what happens with serotonin discontinuation.
Dr. Schwartz, I appreciate you making time for this interview. Thank you.
Thanks for having me out.
My guest has been Dr. Thomas Schwartz, chair of Upstate's Department of Psychiatry and Behavioral Sciences. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes and transcripts at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.